Good day. I'm Dr.K Gireesh, physician, neurophysician, and neurosurgeon. This is the RNA series 37. RNA is nothing but the random questions in neurology and neurosurgery with answers by Dr. K Gireesh. This is to benefit the practitioners of neuroscience and the medical field for a lifelong learning and also for public awareness. In this series, the question which I am addressing is what exactly is the Guillain-Barre syndrome? Guillain-Barre syndrome refers to a very rare neurological disorder. It is named after the French neurologist Georges Guillian and Jean-Alexandre Barre, who first described this condition in 1960. It is an autoimmune disorder where the body's immune system attacks the peripheral nervous system. This can lead to muscle weakness, numbness, paralysis, starting in the extremities from below upwards and spread upwards. In severe cases, it can impair the breathing and become life-threatening. The symptoms are weakness or tingling in the legs and arms, difficulty in walking or climbing stairs, paralysis that can spread from the lower limbs, upper limbs, chest, and to the face. And there is loss of reflexes in all the four limbs. The exact cause is not known, but the Guillain-Barre syndrome often follows an infection such as a respiratory infection or a gastrointestinal infection, especially from Campylobacter jejuni. Viral infections, example Epstein-Barr virus, Zika virus, influenza. Now, what is the treatment for this? Intravenous immunoglobulin or plasmapheresis to reduce the immune attack. Then, of course, supportive care like physical therapy. Some might require a ventilatory support when the respiratory muscles are involved. Most patients recover fully or partially over time, though it can take weeks to months. The administration protocol for intravenous immunoglobulin in Guillain-Barre syndrome is as follows. The dosage is 0.4 gram per kilogram per day for 5 days, a total of 2 gram per kilogram body weight. The baseline vitals will have to be measured: the blood pressure, heart rate, temperature, and oxygen saturation. Ensure good hydration to reduce the risk of renal complications. Use a large bore intravenous line for infusion. The infusion rate, you should be from gradually increase it to the minimal side effects. Start at 0.01 to 0.02 ml per kg per minute for the first 30 minutes. If well tolerated, increase gradually every 30 minutes up to 0.08 ml per kg per minute. Typical infusion time ranges from 3 to 6 hours, depending on the patient tolerance. Intravenous immunoglobulin always comes pre-prepared and this need not be diluted unless specified by the manufacturer. The vitals will have to be checked every 15 to 30 minutes during the first hour. After the first hour, monitor every 30 to 60 minutes. Watch for adverse effects, especially hypotension, headaches, chills, or allergic reaction. And the post-infusion care after intravenous immunoglobulin, you should monitor for delayed reactions, like the common side effects of fatigue, headache, fever, or myalgia. Rare complications like renal impairment, thrombosis, or aseptic meningitis. Ensure hydration. Encourage oral or IV fluids post-infusion to minimize the renal complications. And assess the neurological status regularly to evaluate for the improvement of GPS symptoms. The prognosis, while recovery is possible, some individuals may have lingering effects like fatigue, muscle weakness, or nerve pain. Early treatment improves the outcome. Several scientific studies have investigated. Some might wonder, the role of corticosteroids in Guillain-Barre. Well, several studies have investigated the role of corticosteroids in the treatment of Guillain-Barré syndrome. A comprehensive Cochrane review analyzed the data almost from 6 trials involving around 887 participants and concluded that corticosteroids, when used alone, do not significantly hasten the recovery or affect the long-term outcome in GBS patients. The review also noted that oral corticosteroids might delay the recovery, and the use was associated with increased incidence of diabetes requiring insulin treatment. Well, another systematic review published in the journal Brain found that oral corticosteroids administered for 2 or more weeks significantly slowed the recovery in the Guillain-Barré syndrome patients. The same review indicated that while intravenous methylprednisolone has been studied, its benefits remain uncertain. Further research, including a network of meta-analysis, concluded that corticosteroids have no considerable impact on the course of Guillain-Barré syndrome. In summary, the current scientific evidence suggests that corticosteroids, including methylprednisolone, are not very effective as a standalone treatment for Guillain-Barré syndrome and may be associated with adverse effects. The standard treatments, such as intravenous immunoglobulin and plasma exchange, remain the preferred therapeutic options. Intravenous immunoglobulin is a well-established treatment for Guillain-Barré syndrome, and that's an acute inflammatory disorder of the peripheral nervous system. A comprehensive Cochrane review concluded that intravenous immunoglobulin is as effective as plasma exchange in hastening the recovery in the Guillain-Barré syndrome patients. That particular review also noted that combining intravenous immunoglobulin with plasma exchange does not provide additional benefits over either treatment alone. So it can either be intravenous immunoglobulin or plasma exchange therapy. The timing of intravenous immunoglobulin administration is quite crucial for the optimal outcome. A study published in Muscle and Nerve found that the early initiation of intravenous immunoglobulin therapy, particularly within the first 2 weeks of the symptom onset, is associated with better prognosis. Delaying the treatment beyond this period may diminish its therapeutic effectiveness. In cases where patient exhibits a poor prognosis after an initial course of intravenous immunoglobulin, a second course can be considered. Research from the International Guillain-Barré Syndrome Outcome Study, IGOS, suggests that a second intravenous immunoglobulin course could improve the functional outcomes in patients predicted to have a poor prognosis. However, the decision to administer a second course should be individualized, weighing potential benefits against risks such as anaphylaxis, acute kidney injury, thromboembolic events, and hemolytic anemia. Overall, intravenous immunoglobulin remains a cornerstone in the management of Guillain-Barré syndrome, with early administration being pivotal for enhancing the recovery prospects. That's in brief on all aspects of Guillain-Barré syndrome. Thank you. Thank you very much.